So, Doctor, today we're going to talk about hospital epidemiological investigation. In the first video, we talk about hospital epidemiology. What is epidemiology? Epidemiology is a basic science in public health. What is hospital epidemiology? It's a science that helps us to study the causes of appearance, propagation, and maintenance of problems in the hospital population in order to prevent them. What is epidemiological research? It's the one that helps us to identify healthcare-associated infections, sources of origins, and routes of transmissions. What is hospital or nosocomial infection? Well, this is an infection that you acquired during your hospitality in a health center care, and the first cause is an infectious agent. What about epidemiological surveillance? It's a collection, analysis, and interpretation of information on risk and damage to health. Why? To prevent them. We have the epidemiological surveillance in hospitals. With this, we have to focus on three variables: time, place, and person. Why? To prevent and control. Well, then we have some epidemiological definitions. First, we have endemic, which is a frequency of cases in a defined population in an established period of time. Endemic is a frequency of disease and agent constantly present with high incidence or prevalence. Epidemic outbreak is an aggregation of a disease in a time or space with numbers greater than expected. And nosocomial infection outbreak is an occurrence of two or more cases of hospital-acquired infections with a higher expected incidence. What about the measurement of hospital infections? Well, we have four indexes. The first one is overall hospital infection rates, the second hospital infection rates by type of infection, then rates by device, and special cases. In the first one, we have cumulative incidence, which is number of new cases over number of people under study multiplied by K. Then the incidence density of hospital infection is new cases observed over sum of periods at risk per K. And hospital infection rate, we have total hospital infections observed over number of susceptible people per K.
Communicable disease, it occurs by transmission from a source to a susceptible host. From this, we have the epidemiological chain, that is the sequence of elements involved in transmission. We have the microorganisms that in them the bacteria is the most relevant. We have a source of infection, that is a place where the agent is found and passes to the host. It can be a reservoir or the environment. We have a susceptible host, that is an individual who is the target of the agent and in whom the transmissible disease develops. We have a transmission mechanism, that is a mode by which the agent is transmitted, maybe direct or indirect. We have a door of entry and exit. This is a path. Well, is the path taken by the agent to exit or entry to the susceptible host. And control and prevention measures. Control measures are applied during the disease, and prevention measures are applied before or at onset of the disease progression.
Is a significant increase in the HAI rates in the period when compared to endemic rates. The outbreak recognition is any unusual increase or flare that is easy to recognize. When the basal rate is high, it is much more difficult to identify it. The outbreak investigation is to prevent or avoid the spread of the outbreak to other hospital services or to the community. The lines of action: we have first investigation and then preparation. Success in investigating an outbreak depends on the preparation achieved prior to action. The three main stages are: first, initial evaluation, that is the verification of the diagnosis of the reported cases, the rule outs of the outbreak, and ACEs, the magnitude of the problem. Then we have the outbreak investigation, that is active state finding, establishing the existence of the outbreak, applying descriptive epidemiology, determining who is at risk of becoming ill, developing hypotheses, and implementing immediate control measures. And the last one is the analytical evaluation, that is the association measures, implementation of specific control measures, evaluation of the measures, and final report. We have now the characterization of time, place, and person. First, time. We use the epidemic curve that shows the course of a disease epidemic by plotting the number of cases according to the time of onset. This shows the pattern of spread, magnitude, trend over time, and probable period of exposure. Then we have place, that are places of importance to investigate, carry out the route of the cases, data, and admission, history of hospitalization depending on the disease. And person is more individual, such as characteristics as age, sex, comorbidities, relevant clinical history, etc. Index case is the first case to be recognized in a series of transmissions from an agent in a host population. And then we have the contact, that is the exposed individual who may have been affected by transmission. The outbreak closure is any communicable disease outbreak that can be certified as closed when the maximum incubation period of the disease has elapsed without new cases of the same, as for example, COVID-19. The qualitative tools: we have two: the nominal group that tries to identify problems or solutions and rank them in order of importance. And then we have the cause effect diagram, that is to display information about an effect in a condensed form and identify the cases or contributing factors by grouping them into categories, as we can see here in this image found.
And now, just to put this concepts in practice, we're going to review this study made by a team in a private hospital in Germany that was treating an outbreak in their hospital of Pseudomonas aeruginosa. Well, first of all, we need to know what Pseudomonas aeruginosa is. Pseudomonas aeruginosa is an infectious disease. Well, it's a bacteria that causes an infectious disease that is nosocomial. What this means is that it is usually found in hospitals. It's very infectious, it's very contagious, but it also has the capacity of mutating, and it has a lot of strains that are multi-drug resistant to a variety of antibiotics. So we can see that in this study, all the epidemiological surveillance steps were followed as ordered. First, they detected the patients that were infected with the strain. They were tested, and they were made sure that they had Pseudomonas aeruginosa via they experienced pus. They experienced esophageal secretion. I don't know, various clinical tracks that they had this infection, and then they started testing every single object in the ICU just for knowing which of the objects were infected with this bacteria. So they followed up every single case that was active, but also all of the patients that were spotted in the ICU, including those that weren't symptomatic at the time, because as we said, Pseudomonas aeruginosa, it's a very contagious disease, and most of the patients didn't present any symptoms until they had passed multiple weeks. Then we saw that the surveillance was successful, since when they identified that the bacteria was located in some bottled still water that were located in the ICU, they retracted them from the ICU, and they started noticing that no more patients were infected since that activity. And although they tested every single object in the ICU, they were able to identify the main focus of the infection.